of Department of Pathology, Blood Center and Immunopathology, Government Medical College, Srinagar. Sir has more than 2 decades of experience, Vice President of HHCN 20, special interest in the blood disorders and the transfusion medicine and hemophilia care. Over to you, sir.
Thank you for the kind introduction. It gives me immense pleasure, and I really thank the organizers for inviting me first time to Vijayawada in Andhra Pradesh, and I thank NHM and Society of Hemophilia Society of Vijayawada for inviting me for the talk. And really, it is giving a very satisfaction. I mean, throughout the India, the things are changing. I mean, you are just seeing the people, the gynecologists, the surgeon, the dental, the oromaxillofacial, they are doing a wonderful job. So it is all because of these gatherings and the CMEs, the awareness program. You have to make the aware, because if we just go back to 2007, I mean, really somebody was knowing about the hemophilia. It is after the 2007 that because of the support of the industry and organizations, the things have been taken about the hemophilia, and people are now coming to know what is hemophilia and what are the various products. The world has changed from plasma derived. We have just gone through the journey in the morning to this afternoon. That really the things have changed from blood products, plasma products, and to the SHL, VHL, and third generation, fourth generation, non-factor therapy, to the gene therapy. So the things are changed. But the thing, the topic which I have been assigned is something different. As a these are clinical challenges in case of the inhibitor. So what is an inhibitor? First one. Need to know what is an inhibitor. We have just been aware about the hemophilia. So inhibitor is nothing else, but it is an antibody. These are my final disclosures and second disclosures. And this is the scope of the presentation. I will be talking about the inhibitors in hemophilia and how the inhibitors get developed in our body, and how we really diagnose and what are the various management options available for the inhibitors, and what is the role of recombinant 7A in case of the inhibitors. So the inhibitor is nothing but it is an antibody, because in case of the hemophilia we just don't tell them they are the patients. We are telling them why we are not telling them the patient, because there is none of their fault. Like we have other NCDs, like we have diabetes, hypertension. So they have occurred because of some genetic and because of the lifestyle diseases, right? But hemophilia has none. They have the genetic defect. So they have the X-linked X chromosome, the factor 8 or factor 9 gene defect is there, which none of their fault there. So they are the person. So they are missing that protein, which really is used for our hemostasis. Because God has given us a coagulation cascade. So which you have the procoagulation and anticoagulation. So in a normal individual, the proteins are there, the procoagulants are there, and the anticoagulants are also there. They are keeping that balance, and so that our internal exam, whenever we get injured, that hemostasis gets is maintained. But in case of the hemophilics, we lack the procoagulants like those proteins in our body, whether it is factor 8 or factor 9. So that is why the anticoagulant part dominates, and we get the bleed. So these proteins are replaced. That is why what is called as prophylaxis or the regular replacement therapy, which is a new name given to the prophylaxis. So the factor, the protein which is missing in our body, whether it is a factor 8 in hemophilia A or whether it is factor 9 in hemophilia B, so we have to replace that. So once we replace in the blood of that person, so that is absolutely same as other normal people are which have that factor. So we are replacing that protein. So what is an inhibitor? That protein, it is a natural phenomenon in our body. Whenever any foreign thing comes to in our body, so our body has a security system, what we call as immune system. So that immune system reacts and makes a defend against that. That is called an antibody. So that doesn't want that anything should attack your body which is not its own. So inhibitor is an antibody produced by body immune system. So protein we inject because all our proteins are not immunogenic. So whosoever proteins are there, so they neutralize the activity of that. So antibody which is produced against the factor which neutralizes its activity is called as inhibitor. So these are the mixed inhibitors. So some proteins carry inherent danger signals, they are immunogenic and they produce antibody, and some are not, they will not produce. That is why we see only 15 to 30% of hemophilia, severe hemophilia get inhibitors. So 70% don't get. So that means their immune system, the proteins which are there, they are not recognized as foreign proteins. So these are the protein immune system and these are tag system. So these are the just overview of the inhibitor. One needs to understand what is a really an inhibitor. It is nothing but is an antibody. We just neutralize the factor 8 or factor 9, whichever we replace. So these have the immunogenic proteins and they form the inhibitor. So these are the impact of inhibitors because when we regularly replace the factor into the body, so the antibodies are produced there. So that antibody will just neutralize the effect of that protein, and your factor will not work, it will not give the hemostasis. So it is very difficult to treat the bleed, and you have the severe life-threatening complications, you have the joint disease, and you have the lot of breakthrough bleeds, and ultimately your quality of life gets improved. So these are the basic challenge of the inhibitor. So now, who are the persons who are getting the the inhibitor? It is not that everybody gets inhibitor. It's only some. There are some factors like genetic factors, and there are some environmental factors. So genetic factors are some mutations, like I just do that. So before going to that risk factors, so we need to know some terminologies like exposure days. Exposure day is a just you are pushing a factor into the person of hemophilia. So per day, if you are pushing one injection, that is one exposure. Sometimes if you have two injections in a per day, that is also one exposure. So the bleeds, it means 24 hours, whatever factor you inject is one exposure. So that one needs to know while I will talk about the screening of the inhibitors. I will talk about the exposure. So exposure day is one injection or two injections in a day, that is one exposure. Whatever dose you take in per day, 24 hours, that is one exposure. So this is the exposure day, and these have been PTP and PUP, which is previously treated person and previously untreated persons of hemophilia. So who have just completed 150 exposure days is a previously treated person, and who have never injected a factor is a previously untreated person. So these are the risk factors, genetic factors. In the who have such types of mutations like intron 22, they have the more risk of developing. They have 35% risk of developing inhibitor. And who have the missense mutation, they have 5%. And other factors are ethnicity. You have family history of inhibitors, and you have polymorphism and single nucleotide polymorphism of dominant factor alpha. And they are the persons who are having the more risk of getting the. So these are the genotypes. And then there are treatment related, what we call as environmental factors, which are playing important role in case of the hemophilia. So it depends about the initial dose, severity of the hemophilia, severe, mild, or moderate. So it is usually you are pushing more concentration of the factors in case of the severe hemophilia. That is why the severe hemophilics are more prone to get, because you are pushing more antigen load into the body. Because protein factors are antigens. So more antigens you are exposing to the body, the more chances are, there to get the antibody against that which is called. So age of the patients, even in case of surgery, because there is a set of stress, surgical stress, and other factors are there which lead to the antibody formation or what we call as inhibitor formation. So these are the genetic and environmental factors. So it has been said that the exposure age, what we say that it is only the first 150 exposure days. So if you are a person, you are pushing 150 exposure days to him by the factor 8 or factor 9. So if he has not developed the inhibitor within 150 exposure days, so you have to presume that he will never get in lifetime the inhibitor. So it is only in the first 150 exposure where the risk of inhibitor development is more. So you have to be sure then after 150 exposure, because then the body's immune system learns that no, this factor is my own, I will not produce an antibody. But it's called a self-tolerance. So it tolerates its own those foreign proteins and it doesn't form the inhibitor against that. So that is why the first 150 exposure is very important. That is why whenever you start a treatment on a previously untreated patient, so you have to monitor his inhibitor status. I mean, for first 20 exposures, every 5 days you have to screen for inhibitor. Because it is recommended that for every 5 exposures, for every 5 exposures, for 20 exposures. That means for 4 times in first 20 exposures, then after every 10 days, after 50 exposures, and then after this 6 monthly and then the yearly after 150 exposures. So you have to, those are the guidelines for how to screen for up to 150 exposure days, because the 150 exposure days are the first 150 exposures are the more frequent for developing the inhibitors, and after 150 exposures you can just yearly monitor the inhibitors screen for the patients. So then diagnosis and management. How we are going to know that we are treating our patients for the whether it's factor 8 or it is factor 9. So in your clinic or in your health, hemophilia care center, the patients are coming there. So how you will be knowing that how your mind should go that there is an inhibitor. So the first thing is that the clinical sense, the history. I mean, you are treating a patient, he was coming, whether it's on demand or prophylaxis, so he was very well going by your treatment. But suddenly you see that even I push the routine dose, the normal dose, even the higher dose to the person, but still he is bleeding. So why he is bleeding? So your mind should go towards the inhibitor. That something that body has reacted, the antibody has been formed, even if I push the same dose, but still he is bleeding. So you have to go for the screen. So this is a clinical sense. And your factor consumption is more. Previously you were treating with the same dosage, but the bleed was okay, the patient was going okay. But even if the same dose I am using, I am escalating the dose also, but still the patient is bleeding, is not responding. So your clinical mind should go towards the inhibitor development. So, and there are, if the person was on prophylaxis, there are more frequent breakthrough bleeds during that. So your mind should go towards this. So the clinical suspicion is very important first before going to the lab. So because that is the basic thing your mind should know about the inhibitor. Then the lab. That when your clinical suspicion is sure that no, there is something happening, I am pushing the dose, I am giving the routine dose, I am escalating the dose, but still the patient is bleeding. So now I have to go for the inhibitor screen. So inhibitor screen is a very simple test. I don't know about the Vijayawada district and the different hemophilia care centers here, whether they have the ability of PT and APTT available. PT available. So it is very great news because most of the India, even in medical colleges, there are no available PT and APTT. It's a basic routine test. So if you have a PT and APTT test available in your center, you can do a inhibitor screen, very simple method. So inhibitor screen you have to do. Firstly, you have to take the patient sample. So you will do the test of APTT as per the normal standard protocol. So if APTT of the patient is prolonged, if it is 60 seconds, right? So now what is the next step? This is T1. This is test 1 that you have 60 seconds of that patient. right? Then you do you have a normal control or you have a poor normal plasma which contains an adequate factor 8. So you will mix 50-50. 50 of the patient sample and 50 of the control of factor 8. 50 of poor normal plasma. So you will mix it and put in a water bath and do again a APTT. So usually what will happen? So APTT will be decreased or increased? It will come down because factor 8 will take care. So it should come down. So it should get corrected. So when it gets corrected, so you read that that reading. For example, previously it was 60, now it is 45. So it has come down. So this is called as fresh mix. So but you have to put in a water bath, which is 37 degrees centigrade. So after that you have to incubate it because the inhibitors are temperature dependent. So then you have to incubate it for 1 hour and 2 hours. And after 2 hours you have to again do a APT. So we have made that T1, T2 is a fresh mix and T3 is a incubated mix. So incubated mix APTT. So if it is prolonged again, so first was 60, second was 45, right? So if the third test was 55, so there should be a difference of fresh mix and incubated mix. Fresh mix, if there is, it has been said, if there is a APTT difference of more than 8 seconds, so means fresh mix was 45, if the incubated mix is 55, that means it is more than 8 seconds. So 45 and 55, means 10 seconds is difference. So that means is an inhibitor screen positive. Because what does incubation does? The incubation of 2 hours, there are some dormant antibodies in the our plasma. They get activated by incubation, and that the fresh mix has a factor 8, and that just corrects the APT. But after incubation, those dormant antibodies get activated. So those antibodies are there, and when there is a difference between fresh mix and incubated mix of more than 8 seconds, so your mind should go that it is an inhibitor screen positive. So that patient definitely has an inhibitor. So that is called an inhibitor screen, which each of the labs can do, fresh mix and incubated mix. So after 2 hour incubation, you have that means is positive, and then you can go for the vaccination. Whenever you are performing factor 8 assay, you can do a method assay of also same. There are a lot of we won't go for that detail. But only thing is that if the one website unit you should know is which decreases factor 80 50%. So if your factor 80 is 100%, if you have one BU in your antibody in your plasma, so your factor 80 will be, you are pushing 100, but only result will be after 50. So one Western unit inhibitor will decrease your factor 8 by 50%. So the significant inhibitor are 0.6 Western units, and on this basis we divide them into low titer and high titer, or low responders or high responders. If it is less than 5 RBU, it is low responder. If it is more than 5 RBU, it is high responder. So we categorize them into on basis of the inhibitor status of in the blood. So particularly this is the lab diagnosis. This was the diagnosis. First was the clinical and second was the diagnosis. So low, these are the low and high because of this thing. Then we'll move on again to this thing. So what is the now management part? So diagnosis we have again. What is the management now? How will you treat the patients who have the inhibitors? So there are 2 criteria. If you have low responders, like you have less than 5 bacteria unit in your blood, then the treatment is something different. If you have more than 5, then the treatment is something different. So low unit is better to go for the ITM. What is called as immune tolerance index. Because low bacteria units, they have very less antibodies against a factor. So if you challenge them with more antigens, you will give more factor, and our body will recognize that itself, and the antibody will go, and you will be lifetime without it. So that is why RTI is recommended for the low titer inhibitors. We give higher doses of factor 8, and so that our body recognizes it has own, and the antibody goes. So there are different dosage for that. Less than 5, we start with 50 IU per kg body weight. on alternate days, and you can escalate up to 200 IU per kg body weight, so that inhibitors go. And after 200, you can increase, you can go to 100 IU and you can go to 200 IU. But if after that 6 months your Bethesda units doesn't come before 20, then you have to go for the second line. So these are the weekly best assay you can do after ITI, because you have to see that the antibody is falling down, the inhibitor is falling down, because we are challenging them with high doses of factor this A. These are the second line regimens where we can do the immunosuppression with rituximab. So there is no downward trend of inhibitors. The maximum dosage of 200 IU of factor after 6 months. So then ITI should be stopped. So then what is the other option? So other options are usually bypassing agents. So you have two bypassing agents. You have activated prothrombin complex, ABCC, and you have recombinant 7A. So both are doing well, but we can compare them which is best depending upon the budget and depending upon your availability. You can use both bypass agents for treating the breakthrough bleeds, the patients who are having the inhibitors. So you can have the difference between plasma derived and recombinant. So the only plasma derived is definitely a cheap product, which is a bypassing agent, activated bypassing agent. And recombinant 7A, there are definitely advantages of the recombinant 7A. Because it's a recombinant technology, that is a plasma derived technology. You have a viral transmission in case of the plasma derived products, and there is no risk of TDIs in case of the recombinant 7A. And there is another advantage of recombinant 7A, that you have the reconstitution part. I mean, it takes very easy 5 minutes to reconstitute the drug, and only 5 to 7 minutes to administer the drug. So you can easily treat your acute bleed rapidly. So this is the repetition of the slide which has been discussed already. These are the other advantages of the factor 7A, and in case of the inhibitor. So it will reduce your hospitalization and you have few less of the joint. These are WHO guidelines. So early resolution of bleed is very important to improve the quality of life and just prevent the disability because of the joint bleed. So this is the I just talking about this thing. Faster reconstitution of factor 7A as compared to the APCC. It takes just 5 minutes. Very low infusion volume, that also very important for the patient adherence and patient compliance. Just 5 ml. And its peak activity comes within 5 to 10 minutes as compared to the APCC. So, and there's a faster bleed control, about 90% of the things. So this is a comparison chart between APCC and recombinant factor 7A. You can just see that there is working. So preparation time for the this is 6.5 minutes, and for APCC it is 23 minutes, and for administration it is 5.7 in factor 7A, and for administration of APCC takes 29 minutes. So it has a great impact on the patient adherence and compliance and control of the bleed. So these are some different studies where factor 7A has been remarkable efficacy in case of the acute bleed control. In case of the inhibitors. So this is all other study. So these are the clinical effectiveness of factor 7A in case of the different types of, whether it is spontaneous surgical or severe bleed, sites of the bleed or the severity of bleed. They have proven to be more than 90% efficacious in case of the prevention of the acute bleed in case of the inhibitors. So you can see the between comparison with recombinant 7A and APCC, only 8.3% of the persons of the inhibitors who have who use factor recombinant 7A, only they might need another dose, but 36.4% of the persons who are using APCC are bypassing agent, plasma derived product, they require more dosage. So that means it's a costlier, and half-life is very less, but still the bleed control is more, and the patient doesn't need much more. This is a study where you have a lot of this that to report the safety profile of recombinant 7A over a period of this thing. Best already has been discussed that there are less adverse events thromboembolic events. So even in case of the we have in our center we have 108 patients on non-factor therapy. We have total of 428 patients, and all severe hemophilics are on prophylaxis from last 4-5 years, courtesy to the government and administration and NHM also, because they are also although they have stopped funding from this year. I don't know what is the reason, but it's only because of that thing. We don't have any mortality from last 5 years in our place, and they are doing extremely very well. So just slide that even in non-factor therapy, people are coming with accidents and trauma and breakthrough bleeds. So we use factor 7A for them to prevent injury. Standard half-life. We have all products available with us, and we use them in case of breakthrough bleeds. So it has been used to have the people who are on non-factor therapy. Recommended 7A is recommended, WFH recommends for them the breakthrough bleeds. These are the safety recommended publications which have come in this thing. So it has really very efficacious in case of the breakthrough bleeds who are on the non-factor therapy. So this is the dosage. You can use 90 microgram per kg every 2 days for 3 doses, or one bolus dose of 270 microgram per kg. That prevents the breakthrough. So these are the different types of bleeds and different types of dosages of recommended 7A. And this we have done already. So this is the hemophilia with inhibitors, and this is snapshot. So these are the other. So to summarize, so presence of inhibitors increase the risk of uncontrolled bleeding and disability and premature death. So awareness, clinical suspicion, prompt lab investigation is critical for establishing the diagnosis. Bypassing agents from cornerstone to the these patients, which we have discussed. Recombinant 7A is an effective product that has minimal risk of blood-borne pathogen transmission, faster administration, and onset infection. Recombinant 7A has shown consistent efficacy and favorable safety profile for 20 years of use because it doesn't have any sort of adverse thromboembolic events. So also I just want to thank this thing that so just I was talking about our own center that the importance is that regular replacement therapy. So that is the global standard of care because we have 428 patients. We have severe hemophilia A, B, and viral band disease. All people are on prophylaxis. So we are not seeing any sort of, even surgeries, major, minor surgeries are being done, and everything is going very great. So maybe by this program and other all CMEs, the awareness programs, the government of India will understand that although they seem that there are so many challenges, I projected this year my budget 25 CR, and there were so many questions on me. I mean, we have only 428 patients. Why 25 CR? What is this? Our whole total tertiary care hospital has a budget of 20 crore. So how are you justifying this? So then, when they see the complications, I mean, if you don't have the replacement therapy, then the patient comes with a bleed, they comes with a life-threatening bleed, then the hospital stay, the trial, then the other things. So it reaches to that. When you have no complication, patients are going. Even our patients after 13, one kid got admitted to the school because of this problem. He was not going to school. So at the age of 13, he was admitted at school. People are doing their job. Some are pursuing MBBS. So they are just contributing to the GDP of country. So that way we can just make the policymakers and the bureaucrats and the aware about this thing that look, if you are just making them more healthy, just putting them maintaining their level more than 3 or 5%, so they will be as normal as we are. So they can contribute, and that's my message to all the policymakers. Thank you very much.